Hi all, welcome to STAT's virtual event, How Tech Can and Can't Eliminate Barriers to Good Healthcare, sponsored by Optum. Thank you for joining us. I am Mohana Ravindranath. I am a health tech correspondent here at STAT. I am sure you know how this works by now, but before we get started, we have a few housekeeping items. At the bottom of your screen, you should see several icons. Use the chat feature to chat amongst yourselves or to send a message directly to the STAT team. Please don't put your questions for us in that chat. But if you do have questions that you'd like us to ask during the event, please use the Q&A feature to type your question and we will try to answer it live. In the Q&A window, you should also be able to see the questions that other attendees have asked, and you can upvote those questions that you would most like to see answered. We will be taking questions throughout the conversation, and please don't wait until the end to submit. This is part of what we think makes these events really engaging and fun. We definitely want to hear from you. Thanks for being here. So before we get started, I would like to welcome Dr. Sean Long, who is the Medical Director for Primary Care at Optum Every Care, for a sponsored introduction for today's event.
Hi, thank you for the introduction. Hello, I'm honored to be part of this recording representing Optum, especially considering this topic of technology and telemedicine in healthcare, as it is such importance. Technology and even telehealth-defined services has played a vital role in the delivery of healthcare for quite some time, including technologies such as ambulatory cardiac event monitoring, ambulatory blood pressure monitoring, remote pulse ox, CPAP monitoring, integrated glucose monitoring, and others. However, virtual medical visits has become the technology of the most attention since the start of the pandemic, when necessity thrust it forward as an essential vehicle for delivery of healthcare. Although in use for several decades, the pandemic introduced wide adoption of telemedicine and virtual visits, with primary care and acute visits options leading the way. Telemedicine visits played a vital role in helping healthcare providers continue high-level services during the pandemic, with the more important consequence of launching the use of these technologies into the public eye and becoming mainstream, and a long-term permanent avenue for accessing healthcare. There are often many barriers existing for people to access healthcare. There continues to be underserved, marginalized populations with less access to healthcare, secondary disabilities, socioeconomic disadvantages, cultural disassociation, geographic barriers, weather barriers, language barriers, transportation barriers, and barriers centered around time constraints due to competing priorities. A lot of these barriers are being overcome with the use of telemedicine visits. Certainly limitations exist that cannot 100% be overcome with telemedicine, such as broadband internet and/or cellular connectivity not always available, and interoperability between various devices and browsers. However, the benefit of telemedicine is undeniable, with much higher percentage of the barriers being overcome, and ultimately providing a means of higher quality of care, lower overall. Personally, I have the privilege to serve as primary care medical director for Optum Every Care, where we take extreme pride in our mission to provide the highest quality health care while providing enhanced access through a virtual platform. Providing primary care with wraparound support of urgent care visits 24/7 that includes translation service provides a means for patients to engage in healthcare that may otherwise be neglected, including acute care, preventative care, and treatment of chronic medical conditions. A virtual-first approach to primary and urgent care needs provides a convenient, more cost-conscious option, including a way for the patient to have more control over their care experience. Virtual healthcare visits provide same-day access while limiting the time and cost of travel to a clinic. Healthcare in the palm of your hand, or from the very device many of us work in front of all day. Surveys consistently show that patients confirm their primary health issues can usually be resolved with a telehealth visit. This puts telemedicine in a very patient-centric light. Another benefit of telemedicine is being able to deliver the right care at the right time. Reducing the speed to service can obviously give the patient back time to spend with the family or at work, but more importantly, it can limit disease progression, decrease patient anxiety and concern, build trust with their provider, and ultimately improve outcomes. Technology allows for a home office, back porch, or even a parked car to be a provider consultation room, where a telemedicine visit provides that quicker first access. And when in-person services are needed, patients are referred to integrated labs, specialists, acute care settings, or diagnostic centers. Virtual visits are playing a vital role in facilitating patients' access to healthcare at the right time, the right location, and the right level of acuity, and simultaneously decreasing the confusion that often is associated with a complex, difficult to navigate healthcare system in this country. It is important that wherever people are, they have a seamless transition between modes and locations of care, including between virtual visits and in-person care. Additionally, leveraging EMR technology with population health capabilities improves outcomes with care gap closures, coordination of care between specialties and service locations, reducing duplication of care, and the efficient mechanism of communication for a patient to feel a stronger sense of connection to their medical provider. This all further promotes that patient-centric approach, which connects people to the information, technology, and services they need at the time and place they need it most. Everyone involved in the delivery of healthcare should be excited about the rapid advances in technology-enabled healthcare delivery, and even more excited about what the future can bring by utilizing technological advances to bring higher quality, safety-driven care with better outcomes, and ultimately at a lower total cost of care. Enjoy the program. Back to you, Mohan.
Thank you again to Sean for that introduction. Here to join me for today's discussion, please welcome Eric Bean, who is the Vice President of Regulatory and Government Affairs at Unidus. We have Zen Chu, who is the Managing Partner at Hacking Medicine Venture Capital and the Faculty Director at MIT's Healthcare Ventures and Hacking Medicine Institute. And we have Sylvie Leoten, who is the founder and the CEO of Equify Health. Unfortunately, Bay Gross, who is the Chief Technical Product Officer and co-founder at Cityblock Health, was unable to join us due to personal reasons. But thank you all for being here. So as Sean mentioned in the intro, there are so many barriers that might stop somebody from getting healthcare. If we're talking about telehealth, maybe that's broadband. Sometimes it can be insurance. Maybe they can't find work coverage to be able to get to their appointments. Maybe once they get there, they encounter bias. And I wanted to ask each of you, since you all come at this problem from so many different angles, what specific access barriers are you working to address? Maybe Sylvie, we can start with you.
Thank you, Mohana. Yes, I love this broad context that you put access in, because I often hear about the access as what is happening to get the patient to the hospital and the clinic. So it's insurance or location, but there are also many barriers to access inside health systems. And those are the barriers that I am focused on addressing with my company. I should say that I'm a cancer survivor and healthcare innovator and formerly a technology innovator. And as a cancer patient and a health equity researcher, I found that the barriers inside a health system are much taller than people imagine. So I'm here to talk about them.
Sure, maybe Zen.
Sure. Hi, I'm Zen Chu, and I'm an entrepreneur and early stage investor in healthcare and health tech and reimagined healthcare services. And I also have, for the last dozen years, taught at MIT Healthcare Ventures and Hacking Medicine for a bunch of these techniques. So any things I mentioned today, ventures, I'll disclose, but most of those are just fantastic former students that have created cool companies. And I love that technology scales medicine, right? It's one of the few things that can accomplish the public health aims of the triple aim of both of at the same time increasing quality while decreasing costs and increasing access. And I think those are a bunch of the metrics that we'll be talking about today.
And Eric, it seems like you probably come at it from the side of working with providers and with social services organizations. So what are some of the access barriers that you're focused on at Unidus?
Yeah, that's right. So Eric Bean, I'm the Vice President of Regulatory and Government Affairs at Unidus. And before I joined this company back in 2019, my work was primarily on the government side, working for state government in a couple different places around the country. Our company is really focused on addressing the social determinants of health. And when I think of access barriers, the first thing that comes to mind is transportation. That's a barrier for many people. And we see the vital importance of making sure that those types of barriers are eliminated and that there are ways to track those needs and make sure that those services are ultimately delivered that may impact health in the long run. We also see that there's mistrust of the healthcare system and just challenges navigating it. And you see it all over the country, but often in rural areas, sometimes even in urban areas. And that's why we focus on bringing community organizations on board, and not just social service agencies, barbershops, churches, trusted local organizations with community leaders who can provide true any-door access into the healthcare system, identify needs, and make sure that people are pointed in the right direction to get the services they need, and there's accountability on whether those connections have been made.
And so many of you have talked about these very human challenges of building trust, and making sure that people sort of feel comfortable and safe wherever they are. I'm wondering if you could talk about the limitations of technology when it comes to addressing some of these problems. Are there instances in which you thought technology would be able to address some of the barriers that you focus on? Where did it fall short? Eric, I'll start with you since you're the most recent one.
Yeah, well, I will say one thing is you can't just hand organizations technology and expect that they're going to adopt it immediately and change their workflow. So I do think attention needs to be paid to change management. And while I think that technology plays a vital role in enabling care coordination and facilitating connections between healthcare and social care and government programs, you ultimately still need the humans to make human services work, and that's something that we've learned. It's really important to engage with organizations, understand their needs, the challenges that they're facing, and make sure that as you're asking them to do things in a new way that allows for true care coordination across sectors and silos, that you're sensitive to the operational challenges that they're facing and supportive of their needs.
And just since you mentioned that, can you talk a little bit more about how you systematize that process of, doing that human-to-human reach out? How do you sort of build trust so that other organizations can take up the technology that you've spent so much time building?
Well, one thing that we do that isn't typical of all software companies, we really focus a lot on human capital. We have a networks team whose responsibility is in each state, each community, to do that direct one-to-one engagement that's needed. And over time, we've iterated on our process and figured out an effective way to socialize the benefits of the network, get community champions, work with anchor institutions. It could be a government agency or a hospital system or maybe a health plan, figure out who they collaborate with, but in a perhaps inefficient way, and then bring in the partners that they normally work with. And what we find is that once you get a critical mass of people taking advantage of the system, then more people want to get on board. It can take time, but we have developed a rigorous process and make sure that we hire locally people who understand the community and their needs. And we start with anchor institutions to give ourselves a good running start.
Sylvie, I'll ask you the same question. As you have navigated the healthcare system, both as a patient and somebody who's trying to use technology to bring the patient experience closer to the provider, can you tell me instances in which you thought tech might solve the problem and you found that it didn't?
Yes, I'm hearing all those things about trust, and I can see that there is definitely a divide between communities and health system, as Eric was exploring, and the way his company is addressing is fabulous. I see another component that is not addressed in healthcare, nor by technology, and this is why I started my company, which is really it comes to the human touch you are talking about, Mohana. And when we look at the patient-provider relationship, when you look at patient-provider relationship in the context of cross-cultural differences, a patient that is Black and a provider that is white or a different race, as we know, trust does not always exist in those instances. And I'm a cancer patient, and I know the importance and the influence of trust in the patient relationship for patients for a variety of reasons. But I do not see technologies really fixing or improving that relationship. I think that telehealth, yes, it can improve the frequency of the visit, but how do you really change the dynamics between a patient and a provider? And trust is not something that, happened 50 years ago. It's not something that's coming from, only medical experimentation or the things that happen in the last 50 years, but trust is built every day or lost in every interaction between a patient and a doctor. And I can tell you, as a patient from a marginalized group who is interviewed a lot of Black patients with cancer, that very few of them have trust in their providers. And when what is happening to them every day is actually eroding that trust. So what I'm personally interested in is to look at how I can help improve that trust and that divide, and that it's really coming from a misunderstanding and a misunderstanding of the patient experience on the part of the provider. And this is the gap that I'm working to close. And I'm working on a large project to pilot some new ideas at Emory School of Medicine.
Yeah, and I'd love to hear more about those as well. Zen, I might just ask you though, since you come from the world of venture capital and entrepreneurship, and you advise a lot of the companies that are trying to use tech to solve some of these problems, I'm wondering, have you come across any that sort of pitch technology as the solution to some of these human issues and found that it fell short?
Absolutely. Well, I mean, let's just take diabetes and amputations of feet that that result after many years and decades of having diabetes. But when you look across that patient journey and you look at that endpoint, which should be a never event, right? You should not get to the point where you have to amputate a limb. But when you look at health through a health equity lens, 3 times the rate for African Americans, 2 times the rate for Latinx. And so a great example of a technology that kind of intervenes here is a company that came out of and originated out of MIT's Hacking Medicine, founded by an MIT alum and physician called Podometrics. And it is a diabetic mat that you just stand on while you're brushing your teeth. And it gives you the metrics that it's now proven clinically to catch, I think it is 97% of foot ulcers many weeks before a clinician would. And that is a technology that intervenes. It's an early detection system. It is unbiased, right? And it is now being rolled out nationwide across the VA and some other big providers, because it eliminates those downstream wound costs as well as amputations.
I'm wondering if there are instances in which you're finding entrepreneurs pitching technology as sort of the solution to some of the problems that we've heard from Sylvia as a patient. When I'm thinking about things like automation, for instance, and I'm wondering if any of you have come across instances in which relying too much on technology has actually started to erode trust. And I'm thinking about just, sometimes as a consumer, I sometimes get a little frustrated when I'm receiving sort of automated impersonal messages from companies. And have you witnessed, any of you, have you witnessed this happen sort of in healthcare or even in, the private sector in health technology more broadly, where companies are leaning too heavily on things like automation because they scale, but not recognizing where they start to erode trust with patients? Eric, I'll start with you.
Well, certainly, I think that around the country, there's a lot of concern about privacy, about how data is being used, and specifically in the industry that I work in, the connection between health and social care. People want to make sure that the protections that everyone's accustomed to within the traditional healthcare system under HIPAA are going to apply when you're talking about bringing social care organizations and addressing health-related social needs in order to improve those health outcomes. So we found that it's really important to lead on privacy and security issues, to make sure that people are giving informed consent about how their data is going to be used for care coordination purposes. So the trust factor is something that definitely comes up a lot. And as people have concerns about privacy and data that go far beyond the healthcare space, I think it's important that that regulators not paint with too broad a brush and recognize that there are industries with unique needs and challenges, and oftentimes sharing information in the healthcare context is vital to delivering the types of outcomes that you need. And a lot of strategies, if you think about the movement to do more to advance health equity, will require data to inform the decision-making about where investments and resources need to be applied. So I think it's really important to take a balanced approach, but to take very seriously concerns about how data is used.
And Sylvia, in your experience, both as a patient and as you're trying to build this company, where are you finding that technology can actually start to widen the gap if it's not applied carefully?
I haven't seen that in particular I don't have an example in the case of health equity, but certainly in technology in eroding patient relationship or the patient experience. This is happening constantly. And, I want to make a point that I'm here today because I had cancer. Before I had cancer, I knew that there were problems in healthcare, but I had no idea of the impact of those problems on someone who is facing a life-threatening illness. And this is an order of magnitude. A lot of people are thinking, that, oh, yes, I'm a patient, everybody is a patient. But there is a difference between being a patient and being a chronically ill patient with a life-threatening illness. And, technology didn't really help in my cancer journey. I'm going to give you a very basic example that is very frustrating. As a cancer patient, I spent every single morning 2 hours on the phone just to manage my appointments. And why am I spending all this time when I do not have energy and I have lots of things to do? Because of poor automation. So I'm giving a call to my oncologist at the cancer center. And I have to be put on hold because, it goes through the call center. I have to be put on hold for 20 minutes to get to someone who is just going to take a note and then put you on hold and send it to someone else. And then finally you get to someone and you have to repeat, as your insurance and your medication and all of that. And then you still cannot talk to the doctor. So you have to leave a message for the doctor to call you back. And then you have to make 3 other calls and it's the same thing. And then when the nurse finally calls you, you're in an oncology visit and you cannot take the call and you have to start all over again. So this is a very simple example where there is really an opportunity for technology for example, for what we call single sign-on. There is no reason why I have to make 10 calls back to back. In every single call, I have to say the exact same thing and take so much time doing it.
I think that's a perfect example of an instance in which I'm sure whenever the health system implements this kind of automation, their first thought is, oh, this can make our operations more efficient. But you've experienced that can actually erode the trust that you have, or the confidence that you have that somebody on the other end is listening. And we have a question that's sort of related to how patients can get involved. I'm not sure if this was the intent of this question, but it just got me thinking. I'm wondering how all of you incorporate the kinds of anecdotes that people like Sylvie have of interacting with technology in a way that was not satisfactory. How do you incorporate patients' voices and their experiences into the design process? Eric, when you're working at Unidus, how do you systematize gathering information? Sylvie, how do you apply your experience and the experiences of other patients into what you're building at Equify? And Zen, as you're thinking about when you invest in companies and when you advise them, how do you actually make sure that the patient's voice, the end user's voice, actually makes it into the design process? And Eric, I'll start with you.
The first thing that comes to mind, and this is specific to the social determinants of health technology space, is that the old way of doing things was, at best, you would have a resource directory that would point you in the direction of a community service or a government program, and then the people on the healthcare side would not really know what happened after the fact. There weren't bidirectional communications. There wasn't a master person index. There wasn't longitudinal data tracking. And so you weren't sure if somebody was actually going to get connected to the service, and the onus was on the individual to get there. What we've done at Unidus is create a closed loop referral system that has all those capabilities to track information. And what we've done in terms of human-centered design is focus on trauma-informed care and removing the burden to tell your story again and again and again every time you go to a different provider to meet a different service need. Because many people that we serve have more than just one need. It's actually fairly rare to only see one need. Sometimes that other need isn't uncovered until you go to a community-based organization and they're thankful for the food pantry service and the medically tailored meal, but they say, hey, I also could use some assistance with the home modification, or I have transportation needs meeting my next appointment. And what we do is make sure that record that goes along with the individual is carrying forward only the information that's needed for that next service, but enough information that's needed for that next service that somebody doesn't have to go through the whole storytelling process again. I think on the healthcare side, through all of the investments in high tech to create electronic medical records, a lot of the silos within healthcare were broken down, but what wasn't addressed and is now being addressed is these silos that it's a chasm really between health and social care and all of these other organizations that aren't used to sharing common technology. And that's what we're trying to do and the problem we're trying to solve. And we're keeping the individuals that we're serving first and foremost in our minds as we're thinking about solutions.
And Eric, before we move on, I would love to hear a little bit more about how you actually, in practice, remove that burden. So when you're talking about gathering experiences from the people that use it or whatever, the frustrations that they express, how do you make sure, just down to the nitty gritty of even just, where does that file go? And does it go into some sort of repository that everybody has access to? What does it actually look like to make sure that that doesn't get lost?
So each person only has one record in the system. There is a unique identifier, and we have enterprise master person index capabilities to make sure that anytime somebody goes to get services, that it's attached to that same record, and we avoid the duplication of records. And then what we do is we compartmentalize that information. We don't want anybody who uses the system to serve any person to be able to get access to it. So you will only have access to the records of the people who are referred to you for a service. And we set it up in a way that somebody may need, I'll stick with the food pantry, somebody may need food assistance of some kind. And there's a way to do batch referrals to wait and see which organization accepts it first and says, hey, we can meet that need. And then as soon as they accept it, then the referral is removed from any other providers that may have had access to it. And then the information that's necessary to serve that person is part of that case record that's accessible so that they know, okay, this person has diabetes. We need to make sure that we have appropriate nutritional food that's tailored to those particular needs. And then when they meet that need, if they happen to uncover something else, they may enter something else in that record. And then one thing that we learned along the way is that you obviously need to pay special attention to things like 42 CFR Part 2 if you're serving people with behavioral health challenges. There are also extraordinary sensitivities when you're working with somebody who suffered from interpersonal violence. You want to make very sure that information is not accessible to anybody else. And it may be that somebody has a transportation need who's a domestic violence victim, but that doesn't mean that the person serving them for transportation purposes needs to know that. So there are exceptions to the rule that people who are working with an individual can see their entire case record. There are parts of it that have extra protections. There's extra compartmentalization so that information isn't accessible. And that's something that we put together from a technological perspective when we were working with people, just to make sure they knew for certain that sending somebody to another organization for services wasn't going to put them at risk, that a potential abuser might end up getting access to their information.
Sure. And it seems like in baking those kinds of privacy features into your system are an element of building trust, that people know that the information is not accessible to people who don't need it or who could misuse that. San, I'd love to hear from you when you talk to the company, the startups that you advise, or when you assess potential investments. How do you ensure that sort of the patient's voice, the user's voice is part of the design process?
I think that's one of the biggest opportunities for startups and entrepreneurs and health systems is to focus on, the design principles and needs finding to figure out where the gaps in care are, right, and to automate the hell out of it, right? We have so much redundant and time wasting stuff that bogs our healthcare system down, not just the physicians and clinicians, but nurses and health administration staff. If it can be automated, if that job can be done by bots, do it so that you can give time back for the real human interactions that really suss out, that patient interview and that problem list. There's a great company called Bridge that I'm involved with that records, was founded by a fantastic cardiologist who had been head of innovation at a giant multi-billion-dollar health system, and left to found this company because it was right by the patients to help them understand their medical conversations with professionals, remember them, record them, and highlight and be able to double click on the medical terminology and the jargon, right? Which gives them better health decisions for them. But at the same time, it automates a bunch of stuff for the clinician that saves them hours per day, right? It's really powerful on both sides of the equation. That's, the best use of technology. And yes, you have to make sure that you're not amplifying bias, amplifying systemic bias, right? In these AI models and these big data policies, you can exacerbate biases there's a great book called Automating Inequality that even sheds light on how these algorithms can have unintended consequences, but with the knowledge going in, the promise of the technology is to be able to scale that access.
Sylvie, as a patient, do you feel like the companies that are building technology that is either meant for providers or for patients are incorporating patients' voices enough? Do you wish there was more representation, maybe on certain boards? Patient advocates could be a member of the board, or maybe there could be more routine meetings. I'm just wondering, as you navigate the healthcare system, do you feel there are ample enough opportunities for you to express what your experience has been to the kinds of companies that we have here today?
Yes, thank you for this question. I really don't think that the patient experience is incorporated in healthcare. Regardless of my ethnicity, as a cancer patient, there was really a big disconnect between the patient experience and what providers think the patient experience is. And this is really what enticed me to work in this field. And, I'm not here as a patient. I have 30 years of expertise in technology innovation in Silicon Valley. I happen to have had cancer and have spent a lifetime in human-centered design and innovation. And so I'm really looking at the problem with both the eyes of a patient and the eyes of a designer and a human-centered design expert. And there is really a gap that, as an observer, you cannot understand the needs of patients. You can make assumptions and you can—
I'm sorry, I think we lost your audio for a second. I'm not sure if everybody else did or that was just me, but—
Oh, I'm sorry. As a provider—
There may be an issue. Let me just check with our team to make sure that it's not audio. Can everybody else hear?
I'm able to hear the audio.
I may be the one that lost audio. Let me just check.
Shall I keep going?
Please continue. Let me just check. I can't hear anything.
Okay. So I was saying that as a provider, we can have a provider perspective on the patient experience, but this is not the patient experience. If we interview and we speak to patients, we can have a better understanding, but still I find that this is not enough to really work in the case of racial disparities. It is very difficult to understand what is the experience of a Black patient inside health system. You can have a very superficial view of it, and the example that I like to give is a quote from Japanese philosopher that says that, we look at the world through a straw. We look at the sky through a straw and we believe we see the whole sky. So this is what is happening. Healthcare is looking at the patient experience through and believes that it sees the whole patient experience. So I am building tools to actually empower providers to better understand what it's like to be a patient with a life-threatening illness and what it's like to be a Black patient or a Latino patient or an LGBTQ patient in healthcare. You know, I can give you some really horrible example that I found from my research. You know, first I should say that I'm selling this company. I'm multiracial, Black, white, and other races. And I could say that I'm a cancer patient. I know all this and I'm just going to build this. No, I said that this is not enough. You know, I'm going to go and interview a bunch of other patients to understand their experience and augment my understanding of the experience of marginalized patients. And, you know, in the example of trust, what do you do when a 29-year-old single woman, Black, has cancer symptoms, a large lump in her breast that is enlarging, swollen lymph nodes already, a mother in treatment for breast cancer? She knows that when it goes to the lymph nodes, it's really a problem. She is begging a doctor to get a mammogram and being refused systematically over the course of 1 year, and have to make a scene in the hospital to find a Black doctor to actually give her a referral. I am not making this up. This woman was diagnosed a year too late with very advanced breast cancer. This really erodes the trust of patients in the health industry and health systems. Do you realize what it's like to have cancer, to have those signs, to think that you can die any day, and to not be able to have a provider give you the proper care you deserve because of the color of your skin? It turns out that the provider assumed that she was Black and so she didn't have insurance. She was actually a college-educated, insured Black woman. This is happening every single day in this country. And I realized that when we look at outcomes, patient outcomes, you know, I'm more familiar with cancer and COVID than other illnesses, but my insight was, my God, this is not about finding a cure for cancer. You know, yes, it is, but it's also that we have the technology that we need today to actually dramatically improve incomes by addressing health disparities. And so you're asking how technology can help for that. Technology can help in many ways, but again, you have to start from the patient, not see that it's about lowering cost and all of those things. What I have found in my interviews with patients, for example, is that their systems are systematically dismissed. Their treatment diagnoses are often misdiagnosed. Their treatment recommendations are biased. You know, so you can actually use technology to help this. You know, there are some projects, I know in Stanford, probably at MIT as well, where AI is being used to help with treatment recommendation and, you know, make sure that it's unbiased and that every patient gets the best treatment recommendation. You know, you're a Black woman with breast cancer, you go see a doctor, the first thing he tells you, I've heard this many times, is you need to get a double mastectomy because people like you know, and or worse, Black patients with insurance get sent to shabby, dilapidated clinic for treatment that failed them just because of the color of their skin. Technology needs to help in those things and can help, but it's not something that people in laboratory can do without understanding the patient experience and the insights that I'm describing right now. So I'm building a company that is going to help empower providers to get those insights so that they can build the technology to actually address those unseen barriers in healthcare today.
Yeah, I wholeheartedly agree. You've got these very human issues that result in the very human trust issues, and the technology can bridge it, right? When we're talking about diagnostics that are unbiased, that are at the root, like podometrics, the root cause of that wound that results in an amputation. You've got to look at the underlying, circulation of the tissue, and you can do that in an unbiased way with technology. But it can also be used in problematic ways, and so you have to have that lens of health equity and unconscious bias as you really think about redesigning care paradigms and care workflows, and how the technology fits into the patient journey.
Yes. I mean, I find that it's very difficult to have that lens, that equity lens. I think that, people have very desirous of having that lens, but I give you a very simple example of, empathy. As a patient, I found that people could not empathize with me as a cancer patient. And people assume that empathy is something that everyone can do. Empathy is the first building block of human-centered design, right? So you're going to empathize with the patients in order to understand their needs and then build tools to address their needs. The problem is many people adopting human-centered design, technology companies included, I used to teach that in technology, are unable to really empathize and understand the true needs of the patient. When you add the layer race on that gap is even larger. And I find that even with the best intention to be unbiased, it's still practically impossible to actually have that unbiased view of the experience. And so this is why I'm building tools to help address bias, but they are rooted in the patient experience so that I can empower providers to augment their desire to understand patients and understand their experience to build solutions.
I want to talk a little bit about the funding environment for some of the kinds of ideas that we've talked about. I can imagine when it comes to venture capital, especially for things like health and health tech, there's pressure to automate and to be able to scale, which seems like it could be sort of antithetical to some of these sort of human-centered one-to-one conversations that we're talking about. I'm wondering if each of you can talk about sort of balancing those two things. If you're operating in an environment where you need to raise money to be able to build this kind of technology, and yet you need that inherently, you sort of need that layer of one-to-one conversation with patients to be able to build something that doesn't erode trust. How do you balance those two things? And Eric, I'll start with you.
Yeah, that's a great question. I'll start by commenting on the social care space. I think there's a pretty broad understanding that our healthcare system could operate in a more efficient way, and that it's possible to drive towards better outcomes and to do it with less cost. And I think one of the underpinnings of the suboptimal system we have is the high amount of money spent on healthcare, relatively little spent addressing health-related social needs and social care. And so I think that's where there's an opportunity that's presented. And it's the kind of problem that government could, in theory, solve by creating statewide infrastructure that's addressing all of that fragmentation, that's enabling coordination, that's collecting data to diagnose where we're seeing disparities and pointing towards the solutions that over time can close those gaps. But government always hasn't historically stepped in to do that. And so that's where I see the importance of venture capital coming in. When the public sector isn't doing it, and there is a better way, somebody has to step in and do it and come up with the ideas and the technological solutions that could support this system transformation effort. That's why I was happy to make a pivot actually from government service to the private sector, because it was a company that had this mission that was solving the problem and driving towards the outcomes that as a government leader, I was trying to achieve from the policy perspective. And as I was listening to Sylvie, I think the individual stories are the most compelling thing. But one thing I was wondering is, what's the role of government here? Where is the shared accountability as a country or within a state to look at these longstanding disparities and do something about it? I think that funding is one piece of it. I do think there are regulatory levers that are important too. If we've been looking at these same disparities and inequities for generations, like, why don't we start holding the people accountable who are doing managed care, who are running government programs, to start to shift investments to support strategies that are going to close those gaps and measure the improvements over a course of years? And maybe everything people try isn't going to work, but if everybody's trying this around the country and if there's some flexibility for different companies to take different approaches, then I think over time we'll figure out what's working and we'll figure out a better way to do things. But I think the investment in the space is a really critical thing. But so is the humility that requires stopping and just like looking to see what's actually working.
And do you see opportunities to work better sort of with venture capital and having venture capital work better with government to sort of ease some of those issues you're talking about? And Zen, I'm just wondering sort of in what capacity you see better collaboration between venture capital, the investors themselves, but also just the companies that are funded through venture capital to sort of, be able to ease some of the things that government may not be stepping in to do.
Yeah, I think that's a really complex question, right? But venture capital is very clear in terms of the rationality of their organizations, right? They are there to make good investments, build companies that will return money. I think you have these other impact funds and venture philanthropy that are focused on more of, impact too. But here's the most important thing, which is healthcare is undergoing a revolution on multiple fronts, right? Multiple tectonic shifts. We've got payment reform. We've got different types of insurance. We've got all of these digital technologies that we've been teaching for the last dozen years, and some have really proven their outcomes now. And that's for everything from the basement of the hospital and pathology and radiology to the front lines of healthcare and telemedicine. And when you have these multiple simultaneous technology shifts, tectonic plates shifting, there are gaps in those tectonic plates. And the incumbents in healthcare, whether it's the health systems or the big med tech companies or the big pharma companies, are trapped in their existing business models and payment models. And so the ones that can fill those gaps fastest are startups. And you combine that with the fact that many of these startups realize, with government prioritization, with new kinds of incentives in value-based care, that they can, in new kinds of care models, integrating technology, change those care models. Many of those will be hybrid care models or virtual care models. And you can deliver better care and better outcomes to Medicare populations, Medicaid populations. And if you can do that, then you can make a much bigger profit on your private pay insurance clients, right? And so the question is, how do you make sure that you can address Medicare populations in a sustainable way? And you've got nonprofits doing that, you've got for-profits doing that. But I think the key theme that we see, we have MIT has technology in its name, but it's that technology can address some of those things. It can't solve the entire thing, but you have to be thoughtful in how you apply technology. But technology scales medicine and healthcare.
Well, someone had asked about cost here, and just since you mentioned that a lot of this innovation is happening sort of within the startup world, and definitely mentioned Medicare as well. It seems to me, at least having reported on some of these companies, that maybe fewer of them than patients would like operate within the world of Medicaid or with uninsured patients. And I'm just wondering, sort of broadly, if you can talk about how to make sure the stuff that's happening on the cutting edge is accessible to people that don't have insurance, or don't go to the providers that have sort of partnerships with these companies. And that is another element of access too, is making sure that even if the technology exists, outside in sort of a different patient population group, how do you make sure that it's accessible to everybody?
Yeah, I think that even sledgehammer new medical discoveries that take low molecular weight heparin, classic, incredible discovery, that took 17 years to really become the gold standard, right? These things take a long time to be adopted, even when they have outcomes. Now, we all hope that pace is increasing, and that cycle is shortening, and we just have to do it with outcomes, right? We have to think about it through a public health lens, and how do we take limited funds, right? We got 17% of the GDP, and we're heading to, I think we're going to blow past 20% of our GDP in healthcare, and still have, poorer outcomes of our peer countries. And that's because of this crazy fragmented healthcare system that we have. And so there are going to continue to be disparities, but the best VCs that I get to work with are all focused on making investments that can close these gaps, and thinking through the lens of the triple aim of public health, and or the quadruple aim when you include burnout, which we've got an epidemic of burnout among healthcare professionals now, and they're dropping like flies and changing careers. And it's a travesty to lose these incredibly skilled and experienced clinicians who are just walking away because they're spending so much time in electronic health records, and facing away from the patient while they type in this stuff. And we've got to reinvent those workflows to make it better for everyone involved.
I know we just have a few more minutes left, so I wanted to talk a little bit about what excites you about technology here. And we've talked a lot about the limitations, but I'm wondering if you can talk about, each of you, maybe a modality, a particular type of technology that you think is well positioned to solve some of the access issues that you're looking at. Sylvie, when you think about, as you build Equify, are there particular modalities that you think are especially well suited to transmit the patient's experience to providers, for instance?
Yes, absolutely. I just purposefully didn't start from the technology because my company would be very different if I'd rushed to build a product. So I'm starting with doing research initially, but I can definitely, and I'm excited about the use of virtual reality and artificial intelligence in that aspect to improve the patient, provide experience, and address bias.
In what way, can you elaborate a little bit more on how AI you think could solve some of the issues you've brought up?
Well, the AI is in, first identifying the different pain points or the places where the system breaks down. So I spoke about bias diagnosis and treatment. There is also delayed in treatment that can be automated and improved. The clinical trial, Black patients, for example, there are only 3% of clinical trial enrollments, but they are not often offered clinical trials. So I know that there are some projects in with AI today that are looking at helping doctors enroll patients in a clinical trial using artificial intelligence. I see it for myself more on the machine learning side, because what I would like is to be able to, I'm building educational tools. So I want to change the behavior and the understanding. So I'm working on a different aspect. So virtual reality can help you be in the shoes of someone else, but using virtual reality just to do that is not enough. There is really, the human touch. What you put inside those virtual reality application is far more important than the technology itself.
Sure.
And then use machine learning can be used in improving the learning experience.
Zen, are there particular types or modalities that you think are well suited to solve some of the issues we talked about?
I think one general lens that I'm using to look across a bunch of different opportunities is algorithmic care, right? How can, and a great example of that is a company that I was among the first investors in called Nurex that delivers, privately to your doorstep brand name contraception to any woman with insurance for basically free. And because they architected their system with the best guideline, based care, they can run patients through a set of questions, help them choose the best product for them, and send it to them so inexpensively. Even if they don't have insurance, it's $15 a month. So when you think about, and this is, incredibly relevant these days, access deserts to contraception. This is a startup that has hundreds of thousands of patients that have been using it for years very safely. You're able to provide care responsibly and manage the exceptions with real clinicians in your state, but you can do it so inexpensively, so much more inexpensively, and with better adherence to the guidelines that it's better care all around. And you can kind of take that business model. And by the way, when these are young, healthy, typically women as the early customers, but hundreds of thousands of them. When we ask them before the pandemic, what would you trust us to deliver for you in care after we've had that relationship, right? 20% said they would entrust us with all of their care. Right. And so there's an age divide, right, with, young patients versus older patients, obviously. But that's where you can actually build and enhance trust with different patient populations by delivering what they need and want.
Eric, what about you?
So most people who know Unidus probably know about our closed loop referral system, which was our core technology. The thing I'm really excited about is what we refer to as our payments technology. And what we're trying to do is address the fact that historically community-based organizations have been under-resourced and undervalued, yet they have so much talent and ability to contribute to improved health outcomes and improved community health outcomes. And increasingly, you're seeing Medicaid programs and other payers and providers willing to pay to address health-related social needs, but they want to do it in a way that doesn't over-medicalize these organizations that don't necessarily need to be regulated in all the same ways that a traditional healthcare provider would. So we've created this lightweight revenue cycle management process where we take fee schedules and produce invoices and allow organizations that provide services like around housing, food, transportation to get compensated for that work. And hopefully that plays a small part in this effort to shift investments and create more equitable communities around the country.
Yeah, and I'm hoping that that all our audience members, we've got a really wide range. It sounds like med students and doctors and providers and technologists will come away from this conversation with a lot of enthusiasm as well for ways that technology could address some of these issues, as well as maybe a more realistic idea of what the limitations are. So thank you so much to our panelists for being here, Eric, Zen, and Sylvie. Thank you also to our event sponsor, Optum, and for all the questions that we had in the chat. Be sure to check out STAT's next virtual event, which is Democrats' Last Chance for Drug Pricing Reform on July 20th. STAT will sit down with key decision makers to talk about the latest developments from Capitol Hill and the White House. More information about that can be found on our website. Thank you again.